Bismillah ar-Rahman ar-Rahim. I think it's time to start. We are late 5 minutes, and today is the second day and the third session today, and it's about commerce and health services. We have three distinguished speakers this afternoon. They will talk about this issue. In addition to that, the e-commerce will be handled and addressed by Dr. Al-Salama. The three speakers are Dr. Firas Raad and Dr. Jack Langenbrunner and Dr. Abdullah Salama. It's really my pleasure and honor to introduce the first distinguished speaker, Firas Raad, who is a health care specialist in the Middle East and North Africa region of the World Bank. He has graduate degrees in international relations and public health and is currently working on his PhD, doctorate in public health at the Harvard School of Public Health. He has worked with the UNICEF and the Ministry of Health in Jordan on issues to do with family health, disability, community-driven development, and overall health planning. From 1997 till 2000, he served as private secretary for health affairs at the Royal Court, providing policy advice on health sector issues. His primary areas of research interest are health systems analysis, trade in health services, and health equity analysis. He has publications in the areas of family health and cross-border health programming. Please welcome Mr. Firas Raad to address the trade in health services and national perspective.
Thank you, Mr. Chairman. Can we get the slides up on the screen? Bismillah ar-Rahman ar-Rahim. Thank you, Mr. Chairman. I think it's indeed maybe a blessing to be the first speaker after the lunch break. This way I can avoid the difficult and penetrating questions. But it's indeed a great privilege to attend the conference, and I do salute the efforts of its sponsors and organizers, the King Faisal Specialist Hospital. And indeed, I do believe that this conference is long overdue in our region, and I'm glad that finally our friends and colleagues really have taken this initiative here in the Kingdom to bring us together and to shine a spotlight on the connection between economic analysis and health and how the former can serve the latter. Today I'll be presenting on a subject that is quite close to my academic life, a topic that connects economic, trade, and health, and one that I feel is of growing importance. I first became interested in this topic while I was working and residing in my home country of Jordan. And indeed back then, and I still indeed feel that it's very present to this day, there was an inbuilt tension between trade policy and health policy. And we had two different competing agendas. I shouldn't say conflicting, but competing to a certain extent. An agenda that asked the question, how best can health services promote trade policy? And another agenda asking the question, how can you protect health policies and health sectors from increased liberalization in trade policies? My presentation today will be on cross-border trade in health services within a regional perspective. I originally titled my presentation within a narrower national experience, our own experience in Jordan, but I thought for the purposes of this conference it would be better to indeed broaden the presentation. You may ask yourself, why is trade in health services important? Why is it relevant to our world today? And indeed, the quick and easy answer to that question would be, well, it's here anyway, and to address it and deal with it, it's best to pay attention to it. Some of the factors that make it relevant to our current world today. First, there's been an explosive growth in global trade and services between 1980 and 2000. In our world today, it's estimated that the monetary value of trade in health services has grown from 364 billion to 1.4 trillion in a span of 20 years. There also have been multilateral trade agreements, most prominently the General Agreement on Trade in Services. There are other agreements dealing with products and intellectual property rights, but this agreement deals specifically with services. And inbuilt, and I will get to this in a while, there is an inbuilt liberalization, a progressive liberalization agenda within the WTO that makes it, I think, increasingly relevant to countries to pay attention. The growing trade in health services presents important opportunities and different risks to the health sectors, and I will be getting into some of them in detail. Just a quick footnote in terms of the opportunities. Some people have estimated that the global telehealth market now is estimated at $1.25 trillion. So indeed, there are quite important opportunities for economies around the world. Quickly, some background on WTO and for the General Agreement on Trade and Services for those who aren't familiar with these organizations. It was created, the WTO, in 1995 to better regulate global trade. There have been two rounds of multilateral trade negotiations. The WTO was created in 1995 following the Uruguay round, and since then there have been six, or will be six, ministerial conferences. The first one being in Singapore in 1996, and then an important one in Doha in 2001, and now in December in Hong Kong in 2005. The countries of the world, the members of the WTO, will get together to discuss how to push the agenda forward. The three major agreements are the GATT, the General Agreement on Tariffs and Trade, and this agreement primarily deals with products. The GATS, the General Agreement on Trade and Services, and it covers many different sectors, a whole spectrum of different sectors, and TRIPS, the trade-related aspects of intellectual property rights. And this last agreement received considerable attention in recent past because of the concerns from public health professionals over how this trade agreement would impact the access to drugs, particularly in some of the poor income countries. The basic structure in a nutshell of the WTO agreements, you have the three agreements covering the three areas, goods, services, and intellectual property rights. And you have, for each agreement, basic principles, details, market access commitments, dispute settlements, a specific mechanism to actually deal with the disputes and how to settle them. And then there's certain rules about transparency. And I think this is a very positive aspect of the international trade agreements, is that everything is transparent, everything is online. Anyone can get on the website of the WTO and know what the exact commitments and the exact exemptions claimed of each country are. And I think this builds confidence in the international trading system. The GATS agreement has 29 different articles, and it lays out different governing rules. And indeed, it's quite flexible. It covers many different sectors, except some sectors to do with procurement, government procurement, and civil aviation. But it allows countries really to choose what commitments it wants to make in each and every sector. It does require some general obligations, and the general principle of most favored nation is that each country should treat each other member country equally. And if it does not want to commit to that general obligation, it has to state so upfront and for a given period of time. And I think the maximum period is 10 years. It structures a process of commitment making and exemption claiming. There are horizontal commitments that run across all of the sectors, and for example, land acquisition, equity, capital participation, human resources. These are obligations that cut across all of the different sectors. Then there are vertical commitments to do with each sector. Market access, for example, how much access you want to allow foreign insurance companies or hospital companies to come into your market and and build or provide insurance policies. And then in terms of national treatment, you have to specify that you will treat foreigners the same way you treat your own locals. It does map out a process for progressive liberalization. As I said, once you do commit, you are sort of locked into an agenda that progressively liberalizes your sectors. And it ties the agreement to a structured dispute mechanism, which I think is a very positive aspect. The modes of supply under GATS, they define 4 modes: a cross-border supply of services. Mode 2 is the consumption of services abroad. 3 is commercial presence. 4 is movement of natural persons. And in the area of health, for example, mode 1 really refers to telemedicine, telehealth, telepathology, and I think this is a booming industry across the world. And as Dennis Strevler in his presentation indicated, there is great movement in this area. Mode 2, consumption of services abroad. It refers to medical students traveling for health education, medical education, or patients traveling overseas for treatment. And indeed, here in the Middle East, we have seen a lot of activity in this regard, both within the region, different countries, Lebanon, Jordan, my own country, Dubai, here in Saudi Arabia, in Egypt, in Tunisia. There is growing interest in how these countries can benefit from growth in their health sectors to further promote the growth of the economy. So there is a view that these services can really form a growth sector for the economy. And then on the other hand, you have many patients traveling overseas, leaving the MENA region to be treated in Europe and North America. And indeed, after having worked in the Gulf countries for quite a while, we are estimating that the number of patients who get treated abroad are quite significant, and the value of the money spent is up into the hundreds of millions of dollars. In terms of commercial presence, this is allowing foreign companies, as I said, to establish commercial presence in your own markets, whether they're insurance companies or companies that manage or build hospitals. And many countries around the world have claimed exemptions. They haven't allowed for companies to come into their countries and indeed build facilities. And this really goes back to the social values, the health policy priorities of each individual country. Movement of natural persons are people traveling abroad, working abroad, be them if they're physicians, nurses, or allied type professionals. And in MENA, we do see a lot of this type of activity from the non-GCC to the GCC, even from without the region, nurses in particular coming from South Asia to the GCC, and physicians from the West traveling to work here. Some of the early critics of health services under GATS pointed to different adverse impacts, perhaps, of trade on health. And they claim that there could be an impact on health by distortion of priorities, that promoting trade policy over national health policy goals would become the wave of the day. And this, indeed, we have seen it in different countries. I have witnessed it in my own, where the macroeconomists, the people in the Ministry of Finance, the people in the Ministry of Trade and Industry really set the agenda without sufficient input and feedback from the Ministry of Health. And indeed, many decisions are taken that impact the health sector, but the Ministry of Health and those responsible for the sector are not involved to a sufficient degree. What are the criticisms in detail? They point to several effects that really haven't been well documented and studied yet. They claim that there's a shift in resources away from other services that perhaps service the poor. There could be a crowding out effect of the local population because physicians would be more interested in serving foreign nationals. It does promote a two-tiered system of healthcare, a system of high quality servicing foreign nationals, and a system of lesser quality serving the locals. And there could be a loss of investment in human capital as trained physicians and nurses and other health staff travel abroad and actually stay abroad. So there are positives and negatives, and indeed there are trade-offs for developing countries. When you look at the different health sector objectives, health performance goals, such as equity, quality, and efficiency, you see that the different modes of trade have positive effects and negative effects. In terms of cross-border telemedicine, for example, could be used to serve remote areas. If, for example, primary healthcare centers in rural Yemen send EKGs over the phone to specialists in the King Faisal Specialist Hospital, this indeed, I think, would serve the goals of equity and quality. However, they do entail substantial investments in such technologies. For example, heartbeat monitors that can be used to transmit EKGs are not inexpensive. In terms of consumption abroad, patients going to foreign markets, there could be an effect, as I said, on the foreign nationals, a crowding out effect. It could also lead to a certain brain drain of professionals from the public sector to the more lucrative private sector. And indeed, here in Saudi Arabia, we had discussions, I think yesterday, about how this effect is manifesting itself here in the kingdom, where a certain private hospital was pulling away doctors from a public sector hospital, and indeed the government had to intervene. There are negative effects, and I think in contrast there are positive ones. You can improve your skills. There is a quality improvement impact by treating volumes of foreign patients of various backgrounds, and there is a possible loss of investment. In terms of commercial presence, I think the big adverse impact is maybe the promotion of a two-tier system, and governments have to be attentive to this impact versus freeing up resources. Having companies come in and service your nationals within big urban populations can allow you to spend some of your money elsewhere, particularly in the outlying rural areas. Movement of natural persons, the positives are the remittances of nationals traveling abroad, but in exchange there is a loss of investment given the subsidized education that they received, and possibly a loss of quality and access if these individuals were serving patients from the lower income segments of society. Here's a quick conceptual framework of perhaps how the global trading environment can affect health status. You see in the green circle the health services trade environment and how it's affected by the general agreement of trade and services. And naturally this environment affects export growth, the generation of hard income for the country, and it has fiscal and important human capital effects. Especially vis-a-vis employment generation and training and the upskilling of skills. And this naturally affects the household, and the household behaves in certain ways to affect health status, either through the risk factors medium or by pursuing health services. Now, in response to this phenomenon, the WHO launched a global program on globalization, trade, and health. And its purposes are to achieve greater policy coherence between trade and health, and to really promote an effective health dimension in economic policies. And I think this is extremely important for governments to be attentive to. I have discussed this issue with different representatives from different ministries of trade and industry who have engaged in negotiations with the WTO. And indeed, the representation from the Ministry of Health has been at times minimal. And I think this is something that should be corrected. The trading teams that are put together, or the negotiating teams, should include public health professionals. And the program does support collective action to prevent cross-border risks to public health. The health issues most relevant to WTO agreements, the WTO and WHO got together and formed joint committees, and they looked at the different health issues. And here they are. For the General Agreement on Trade and Services, disease control, tobacco control, health services, and information technology are the recognized priorities of the program. In terms of the Middle East and North Africa WTO members and their commitments, we have so far 10 countries, and we were glad yesterday or before yesterday to hear about the accession of the Kingdom. I don't know if it's official yet, but there was an announcement to the WTO, so congratulations to the Kingdom. I think this is an important milestone. As you see, some of the early countries that joined the WTO were Bahrain, Djibouti, Egypt, and Kuwait, Oman being the last one in 2000, and now the Kingdom. And these are the different areas of commitment that each country committed to. Health insurance, you can see, runs across 4 or 5 countries. Hospital services and health services in Kuwait, health and hospital services and health insurance in Jordan. And by and large, these are the main categories of commitment. What do we know about health service trade and MENA and cutting across the 4 modes? Indeed, we lack good data, quality data on this issue, and I have been trying to fill the gap in my own particular and individual way through my own research, and that is trying to improve the data collection methods that we have now currently in place in Jordan. Surveys are done, but not on a regular basis. More can be done in terms of the general data collection vis-a-vis people coming into the country. When foreigners apply for visas, usually the purpose of visit is requested, but no further detail is requested other than that. And we have tried to push the government to really specify the purpose of visit, so we know how many people are coming in and for what purpose. And this, I think, will help for purposes of planning.
Excuse me, we have time is up.
Time is up. Okay. Well, I will run quickly over these slides. Mode 1, the role of telemedicine. We know of different examples here in the Kingdom, in the King Faisal Specialist Hospital, in my own country, the King Hussein Cancer Center, and in the UAE. Each institution has links tying it to institutions in North America and Europe, and some of them Asia, and there are wonderful telemedicine technologies out there. These are examples from the King Faisal Specialist Hospital. Mode 2, consumption abroad. Quickly, there are many countries, as I said, engaged in this industry. Lebanon, Egypt, UAE, Dubai City is coming up, and indeed Jordan. Patient treatment overseas. We have estimated that the nationals leaving the GCC countries for treatment abroad, primarily in North America and Europe, exceed $500 million. And that's a conservative estimate. Health education services in certain countries, we've seen foreign nationals fill the medical schools. In my own country, one university now, about 60% of the medical students are from abroad. These are some quick figures on healthcare tourism in Jordan and who is coming in and how much revenue is generated. These are revenues from 2 private hospitals, and you can see that the revenues run up into the millions of dollars, and this is only for 2 private hospitals. Some more revenues, and I will run through quickly these. There were examples of Mode 3 and Mode 4, and here, for example, examples of Mode 4, the percentage of health workforce workers from different countries working in the kingdom, and you can see in terms of physicians, nurses, and allied personnel that a large percentage are non-Saudis. Potential benefits: economic growth, employment generation, technology transfer, improving service standards, and greater transparency, things that we've mentioned already. Potential risks are the health policy and health equity impact, the distortion of priorities, the loss of human capital, the limiting of healthcare access to the poor. Some important policies for the MENA countries are maintaining policy coherence, as I have tried to explain, developing in-country capacity to inform GATT's negotiation processes and country commitments. And one thing that I wanted to mention is that quality markets itself. I have indeed tried to counsel my country not to market the services in any public way, that if you really improve the quality, that the marketing will take care of itself. Promoting the portability of insurance coverage. This is something I think quite important and should be worked on in a bilateral way. Data collection and conducting research. Thank you very much.